Okay, let's unpack this. Imagine someone who seems to have it all figured out. 26 years old, living in New York, great job, just got promoted, new relationship, everything's just clicking. That was Suzanne.
It sounds like she was really on top of things, living the dream almost.
Totally. And then, seemingly out of nowhere, things started to go wrong. Really wrong. And in such a bizarre way, it began with, well, physical stuff. She became convinced, absolutely convinced she had insect bites all over her.
Oh, wow.
Yeah, scratching constantly. But nobody else saw anything. Colleagues looked, nothing. They even got an exterminator in, found 0 bugs. One source we looked at mentioned this. Sometimes it's called Ekman syndrome or dermatological delusion.
A real disconnect between what her body was telling her and, well, reality.
Yeah.
That must have been incredibly confusing.
And
frightening.
Deeply. And it escalated quickly. Like on her commute, she'd suddenly feel her body changing size, sometimes feeling tiny, sometimes huge. You know that perceptual thing, Alice in Wonderland syndrome?
Right, I've heard of that. So not just skin sensations, but her whole perception of her physical self was warping.
Exactly. And familiar places started feeling wrong, alien. Her own street felt completely unfamiliar. That thing called jamais vu, like the opposite of déjà vu.
So strange perceptions, body distortions, unfamiliarity, all hitting at once.
Very much. And within about a week, it got even more dramatic. Huge mood swings, like high energy, almost euphoric 1 minute, then completely flat and withdrawn the next. Then came these really bizarre ideas, delusions.
Delusions, like what?
She got fixated on this idea that her father was plotting against her stepmother. And even stranger, she started believing she had mental powers, that she could, age things just by thinking about it.
Wow. Okay, that's a very rapid spiral. From odd sensations to complex, frankly, paranoid-sounding delusions in just days.
Frighteningly fast. And then her physical abilities started to decline. Speaking became difficult, moving became difficult, until she could barely do either. Her family, obviously terrified, rushed her to one of the best hospitals around, a really top-tier clinic.
You think they'd figure it out quickly there?
That's what everyone hoped. But the first round of tests, the standard stuff, MRI scans, EEG for brain waves, all the usual blood work, it all came back. Normal.
Normal? With symptoms like that? How is that even possible? That must have just amplified the confusion for everyone, doctors included.
It absolutely did. Different specialists came in, and they all had different ideas, all incorrect. One psychiatrist suspected bipolar disorder, with extreme mania. A neurologist wondered about alcohol or drug use, maybe withdrawal.
Understandable guesses, maybe, given the presentation, but still missing the mark.
Totally. Then a psychopharmacologist, an expert in psychiatric drugs, came in. They leaned towards schizoaffective disorder and actually started her on medication for it.
And this is where her parents really stepped up, according to the source material.
Oh, crucially. They were divorced, but totally united on this. They just refused to accept the psychiatric labels. They had this gut feeling, this intuition that something physical was fundamentally wrong.
And they fought to keep her in the neurological ward.
Fiercely. There was pressure to move her to a psychiatric facility, but they dug their heels in. And the source makes a chilling point. If she had been moved, she likely wouldn't have gotten the specific physical treatment she needed later. It was almost a fatal mistake, averted by their persistence.
Wow. It really speaks to listening to loved ones, even when the experts are stumped.
It really does. Anyway, the breakthrough came with this neurologist, Dr. Nojar. Apparently, he had a reputation for tackling these really tough mystery cases. He reviewed everything with fresh eyes.
And what did he notice?
He started picking up on things that maybe seemed minor earlier or got lost in the noise of the more dramatic symptoms, like a slight tremor in her hand she'd had early on, or that initial fear about the imaginary insects. Subtle neurological clues, maybe?
Looking for the underlying physical signs beneath the more obvious psychological distress.
Exactly. He saw early signs of catatonia in how she was moving, or rather, not moving much. But then he did something really unexpected. He gave her a clock drawing test.
A clock drawing test? Isn't that usually for, dementia screening in older patients?
That's the typical use, yeah. It seemed like an odd choice for a young, previously healthy 26-year-old with these symptoms, but it turned out to be key.
How so? What did it show?
Suzanne's drawing was really off. All the numbers were crammed onto just one side of the clock face.
Okay, suggesting
that one whole side, one hemisphere of her brain wasn't functioning correctly.
Wow. So that simple kind of old school test pointed towards a localized physical problem in the brain, not a general psychiatric condition.
Precisely. That was Dr. Najar's huge insight. This wasn't just in her mind, so to speak. The bizarre thoughts, the mood swings, the delusions, they were likely symptoms of something physically attacking her neurons.
It reframes the whole picture. The mental symptoms are the result, not the cause.
Exactly. So they pushed her for more tests, a brain biopsy, and a specific analysis of her spinal fluid. They sent samples to another doctor who, amazingly, had seen a handful of similar, equally baffling cases, and they found the other diagnosis, anti-NMDA receptor encephalitis.
Anti-NMDA receptor encephalitis. The sources explain that's a rare autoimmune disease, right? Where the body's own immune system basically attacks crucial receptors in the brain.
Yes, the NMDA receptors. And it often hits young women, just like Suzanne.
And the most critical part.
It's treatable. If you catch it. But it's so rare, Suzanne was only the 217th person diagnosed worldwide at that time. Thankfully, she did get the treatment, she recovered, wrote a book about it.
Brain on Fire, right?
Became a movie, too.
That's the one. It brought so much awareness to this condition that was so easily misdiagnosed.
An incredible story of recovery. But it leaves us with a really unsettling question, one the sources really dig into.
Yeah, and the question is pretty stark. If these top doctors in a cutting-edge hospital struggled so much and almost made a fatal error, what does that say about the reliability of diagnosis for, the average person seeing their local doctor today? It's a huge challenge, isn't it? How do we draw that line? How do we tell the difference between a serious underlying illness, maybe physical, maybe psychiatric, and just, being different or going through an incredibly tough time?
And it's not just theoretical. The sources stress this point. This affects so many of us or people we know. So to help us grapple with this, we're going to pull in some other material you brought. Research on how common mental health issues actually are, what the science says about diagnosis, now the limits, the advances like biomarkers, brain scans, and the models scientists use to understand mental well-being.
Right. Moving from Suzanne's specific dramatic story to the wider scientific view, what does the data show us?
Exactly. So our mission here is to unpack these specific sources and see what modern science actually tells us about diagnosing mental health, trying to get beyond some of the older ideas and see the more complex, evolving picture. Let's dive in. First, let's just talk about scale. How common are these issues, really? One of the sources looked at was this massive, long-term study, decades of data, 29 countries, published in the Lancet Psychiatry.
A huge data set. What did it find about prevalence?
The headline finding is, frankly, staggering. It suggests that by the time someone reaches age 75, 1 in 2 people, half the population, will have experienced at least one diagnosable mental disorder.
1 in 2, wow.
That's kind of
much higher than I think most people assume. It really shifts the perspective from these being rare conditions to being, a common part of the human experience.
Absolutely. And another really key finding was about when these things tend to start. The onset is often surprisingly early.
How early?
The first signs often appear around age 15, and the average age for a full disorder to develop is around 19 or 20.
So adolescence and young adulthood seem to be a critical window. Any idea why?
Well, the source suggests, while it's complex, it might be linked to all the intense biochemical changes happening in the brain during that developmental period. That rapid maturation might also be a time of increased vulnerability, potentially.
Makes sense. A lot is changing then.
And importantly, the study also found that help seeking is often lower in these crucial early stages. People might not get support when they need it most, even though the risk of things getting worse can increase over time. It really underlines the need for better support for young people.
So the takeaway is, if you haven't personally faced a mental health challenge, or someone close to you hasn't, the statistics suggest it's actually quite likely you or they will at some point. It makes it less of an us and them issue and more of a we issue.
Exactly, which brings us right back to that diagnostic dilemma we saw with Suzanne. The sources are very clear on this. We still don't have the equivalent of, say, an X-ray for a broken bone or a blood test for an infection for most mental health conditions.
No definitive biological test, right?
Not in the same way, no. Science is definitely working on it, making progress, but we're not there yet for most things.
So how do clinicians make diagnoses now? What are the main tools, according to the sources?
It still relies heavily on 2 things. Self-report, what the person themselves says about their thoughts, feelings, experiences, and careful clinical observation by trained professionals, often using structured interviews to gather that information systematically.
Okay, but self-report, that introduces subjectivity, doesn't it?
Yeah.
How well can someone articulate what's going on inside? And things like culture, or even just the stress of being assessed, could influence what they say.
That's precisely the challenge, and it's why the hunt for more objective measures, biomarkers, is such a big focus in research, as the sources point out.
But they're not necessarily looking for one single smoking gun biomarker for each disorder, are they?
No, and that's a key point. The sources emphasize the huge heterogeneity, the variability within mental disorders.
Yeah.
Depression can look very different from person to person. Bipolar disorder, too. So the idea of finding one single biological marker that fits everyone with a certain label is kind of falling away.
Right. So if there's so much variation, how do they even establish what's abnormal biologically? How do they identify potential markers?
One approach gaining traction, highlighted in the material, is the normative model. Instead of comparing someone to a theoretical, perfectly healthy brain, they compare an individual's brain activity, or maybe genetic markers or other biological data, to what's typical, what's normative for large groups of people who are similar in age, sex, background, that kind of thing.
Ah, okay. So it's less about finding a specific broken thing and more about spotting patterns of activity or structure that are significantly different from the expected range for that person's peer group.
Exactly. For instance, some studies using brain scans, fMRI, in people with major depression have found patterns like maybe increased communication between the limbic system, the emotional centers, and parts of the cortex compared to what you typically see.
So those patterns become potential biomarkers.
Yeah.
They aren't the diagnosis itself, but they're like extra pieces of objective evidence that can support the clinical picture built from interviews and observation. Adds reliability.
Right. Converging evidence, basically, for the specialists. Now, shifting gears slightly to how we conceptualize mental experience itself. The sources talk about a really common framework used in psychology and psychiatry today. It views the person as a system with three core interacting parts: thoughts, feelings, and behavior.
And the key is interacting, right? It's not just a list.
Definitely not. It's a constant loop. How you're feeling right now influences the kinds of thoughts that pop into your head, how you interpret events. Those thoughts then shape your emotions further and drive what you do, your behavior. And then what you do or don't do feeds back and can change your thoughts and feelings again. Therapists often draw it as a triangle, arrows going every which way.
And problems arise when that cycle gets stuck in a negative or unhelpful pattern. Like negative thoughts fuel anxiety, which leads to avoiding things, which then reinforces the negative thoughts.
Yeah. That's a classic example. But here's a really crucial point the sources make, moving beyond just the symptoms themselves. For many experts now, the defining factor for whether something is considered a mental illness or disorder is the level of suffering and harm it causes.
Suffering and harm. So it's not just about having unusual thoughts or feelings.
Not necessarily, no. It's about the impact. The source gave a fascinating example. Some people hear voices, but they live perfectly functional lives. The voices aren't distressing, they don't tell them to do harmful things, and the person is just okay with it.
So in that case, even though hearing voices is statistically unusual, if it doesn't cause suffering or impairment, it might not meet the threshold for a disorder under this framework.
Exactly. People usually seek help when the experiences become distressing or overwhelming, or when the voices, say, become menacing, or when just coping with them drains all their energy. So disorder gets tied to distress and functional impairment.
That's a really important nuance. It fits with this broader shift in science towards seeing the mind and body as this incredibly complex, dynamic system.
And that system isn't just neck up either. The sources also touch on the growing research around the gut-brain connection. Still needs more work, but it's intriguing.
The gut microbiome affecting mood and cognition. How does that supposedly work?
Well, the idea is that the trillions of microbes living in our gut can actually influence brain function. One possible route is the vagus nerve, which is like a major information highway connecting the gut directly to the brain. So changes in our gut health could potentially send signals that impact our mental state.
Huh. Just adds another layer of complexity, doesn't it? Body influencing mind in ways we're only starting to understand.
It really does. And all this complexity, the interacting thoughts, feelings, behaviors the body influences, reinforces another key idea. Symptoms usually exist on a continuum.
Meaning there isn't always a sharp on-off switch between healthy and disordered.
Pretty much. It's more like a gradient. Think about anxiety. Everyone feels anxious sometimes. But it exists on a spectrum from mild worry to significant interference in daily life, all the way to debilitating panic or phobias that prevent someone from leaving their house. That extreme end is far along the continuum.
Right, like the voice hearing example too, from not bothersome to completely disruptive.
Exactly. And this continuum idea is a big part of why diagnosis isn't always simple or instant in practice. It can take time to figure out if someone is having, say, a really intense but temporary reaction to extreme stress.
Like losing a job or a major bereavement, something that pushes them deep into distress for a while.
Versus whether there's a more persistent underlying issue that means they struggle to bounce back, even with support. Lots of people experience intense distress and recover. For others, that stressful event might reveal a vulnerability that needs more specific help to avoid getting stuck.
Okay, so researchers and clinicians are increasingly thinking in these terms, continuums, complex systems. But then we have things like the DSM, the Diagnostic and Statistical Manual of Mental Disorders. How does that fit in? It seems very much about distinct categories.
Yeah, the sources address this directly. They acknowledge these manuals exist, like the DSM or the ICD internationally, and that they list specific conditions with checklists of criteria. Boxes, essentially.
But they serve a different primary purpose, right?
That's what the sources argue. They're largely tools for bureaucracy, for governments tracking public health statistics, for insurance companies needing standardized codes to process claims, for researchers needing to define groups for studies. They create necessary, if somewhat artificial, dividing lines for these practical reasons.
But they don't always capture the full complexity or the spectrum nature that clinicians see daily, or that researchers are investigating with things like the normative models for biomarkers.
Exactly. There's a tension there. The need for classification versus the reality of human experience. It's why biomarker researchers, for example, often look beyond rigid DSM categories and use these more dimensional or system-based approaches.
It paints a picture of a field that's very much evolving, trying to bridge that gap between practical needs and the deeper, more nuanced scientific understanding.
Definitely. It's complex, ongoing work, but the understanding is deepening, which hopefully leads to better ways to help people. So let's bring it back to Suzanne's story as we wrap up. It really stands as such a stark reminder of everything we've just talked about, doesn't it? The deep connection between physical and mental health, the sheer difficulty diagnosis can sometimes involve, and how high the stakes can be.
Absolutely. Her experience forces us to confront the reality that things aren't always what they seem on the surface. Symptoms that look entirely psychiatric can stem from a treatable physical condition. Figuring that out takes incredible diligence.
And looking back at our deep dive through the sources, several key things stand out. First, just the sheer prevalence that WHO studies suggesting 1 in 2 people will face a mental disorder by age 75, often starting young. It's common.
And the current state of diagnosis. Still heavily reliant on listening and observing, because we don't have those simple biological tests for most conditions yet, although tools like biomarkers are emerging as helpful additions.
Right, we saw the promise, but also the limits of biomarkers and brain scans, useful clues, more objective data points, but not definitive diagnoses in themselves right now.
And the shift in thinking about what's normal or typical, moving to models like the normative model that embrace individual variation within groups.
We also touched on that core framework. Thoughts, feelings, and behavior constantly interacting, and how often it's the suffering and harm caused by these patterns that leads to a diagnosis of disorder.
Plus, the crucial idea that symptoms usually lie on a continuum, a spectrum, rather than in neat categories, even though the diagnostic manuals create boxes for practical administrative reasons.
And finally, that growing awareness of the body's role. Things like the gut-brain axis reminding us it's all one incredibly complex, interconnected system.
Yeah, the big takeaway from these sources really seems to be a move away from overly simple explanations towards acknowledging this immense complexity, mind, body, environment. It's all woven together dynamically.
And the sources make it so clear. This isn't just academic. This complexity touches many of our lives, maybe more directly than we think. It's closer and more intricate than perhaps we realize.
Definitely. It changes how you might think about your own tough times or how you view what friends or family might be going through.
So here's a final thought, something to maybe mull over based on what we've explored. If our scientific understanding of what even constitutes a disorder is still evolving so much, if it depends less on simple tests and more on this complex interplay of systems, context, suffering, and where someone falls on a continuum, what does that mean for how we perceive our own struggles or the struggles of people around us? How could really embracing this complexity change how we approach mental well-being for ourselves and for society?